Thank you for joining me today. In this video, I have examples of clinical case study. Initially, I met Mr. J. He's a 26 years old male. During the in-hospital psychiatric admission, he was brought in by his family after a severe manic episode. He had several days of sleeplessness, pressure speech, grandiosity, and impulsiveness, spending money. So his family brought him to the hospital. He's 26 years old male, and he was in manic episode of bipolar I disorder. He didn't sleep several days. He was impulsive by spending money and abnormally. He was agitated, and this was his third time in a 4 years of hospitalization, and this was the first time he admitted to the hospital in a 4 years. He already had a confirmed diagnosis of bipolar disorder, and during this admission interview, he openly admitted that he had stopped taking his medication because I felt cured. He said, I stopped taking my medication because I felt a cure. At the present, he was clearly manic, hyperverbal, and distracted, and intermediately hostile. So he was hostile, he was manic, he's not cured, but he thinking that he was cured and he don't have to take any psychiatric medication anymore. That's why he stopped taking the medication. Yet he was insightful enough to know he need help. So he need help. He realized after he stopped taking the medication, he realized he's not cured and he need help. So he agreed to come to the hospital with his family. At this point, I began considering a long-term mood stabilizer, not just a acute symptom control, because he needs long-term mood stabilizer since he's not taking his medication regularly, and this is the fourth time he admitted to the inpatient hospitalization. I began considering lithium. The clinical reason of considering lithium was Mr. J had previously tried Depakote, but he gained weight. So he stopped taking it when he realized he's gaining weight. And then he tried Seroquel. So the previous doctors prescribed Seroquel when he complained about gaining weight by taking Depakote. Seroquel, it was partially controlling his manic, but he was not taking it consistent. He was taking it one time and stopping the other day, so it was not consistent. So it didn't work for him. Then he came back to the hospital, and then the other doctor prescribed him with Lamictal. He said that my last doctor prescribed Lamictal. I tried Lamictal and it was not effective and it was not working for him. That's why he admitted the first time here. Then that is the reason I want to consider prescribing the lithium, because he tried Depakote. He don't want to gain weight, so that's why he stopped. He tried Seroquel, and it didn't control the manic episode, so he stopped that. And then other doctor prescribed Lamictal, and it was not effective. It was not controlling his symptoms. However, what stood out to me was that he had a classic pattern of euphoric, manic, clear episodic classes, and relatively few medical comorbidity, fairly associated with good lithium response. So he was manic. He had a clear episodic classes of manic. He don't have other comorbidity, medical comorbidity with besides the bipolar I disorder. After talking to him and talking about the options with the patient and his family, we agreed to initiate lithium. But before we initiate lithium, we have to evaluate the baseline lab. For that case, before I prescribe the lithium, I order a baseline labs and assessment. I order CMP for electrolytes and kidney function, TSH for thyroid level and thyroid function, CBC, urinalysis, EKG, to rule out if the patient have potential cardiac effects. If this patient is a male, but if he was a female, then you want to test the pregnancy to rule out if the patient is pregnant. Mr. Che labs were reasonable. Creatine and EGFR were within normal limit, so his kidney is functioning normally. He had a normal thyroid function, no cardiac conditions. He didn't have any cardiac condition. This cleared the path to be treated safely. So after I check all that lab, it showed me that I can clearly prescribe lithium. Initiating lithium, I started the lithium carbonate for 300 milligram twice a day. Choosing the conservative initiation to a minimum side effects, and I explain clearly. Lithium is not a quick fix. It works slowly, but then it works deeply. So I educate the patient about lithium. Lithium works well and slowly. It's not quick fix, but it works slowly and it's effective. I began giving him 300 milligram twice a day. That is the initial dose. Then I educate the patient about dehydration, salt intake, medication interaction, by emphasizing that the risk of NSAIDs and dehydration and certain dietary changes. Those are the education I give the patient before I initiated the lithium. Also, set expectations. So I set expectations. I explained the patient the blood levels will be checked every 5 days after dose changes. The target TRA level will be 0.8 to 1 during the acute manic. So I educate the patient that we have to check the lithium level every 5 days after the dose changes to know the level in the body, in your blood system. And the target TRAT level that we are expecting should be between 0.8 to 1 during the acute manic. That's what we would like to see it. Long-term goal will be lowest effective dosage. So we will lower the dose after the medication becomes effective. Monitoring and adjustment. 5 days later, Mr. Che lithium level came back at 0.6 ml/liter. Subsequent, which is subtherapeutic for manic. So we have to still increase or continue the medication because it's not the level that we want it to be. Clinically thought, I notice early improvement, less agitation, better sleep, improved organization of speech and thoughts. So even though the lithium is not the therapeutic level, patient improved, sleep improved, agitation is less, so he's sleeping more, agitated less, and he has a organized thought and speech. We increased the dosage to 600 milligram twice a day within other week. So I doubled the dose to reach the therapeutic level of 0.8 to 1. After 1 week, we checked the lab and lithium level came back 0.9. That's good. But the patient had a tremor, mild, that intention based. It was intention based. It was not very risky, but it was mild tremor. And GI said that resolve. Mood-wise, he's significantly calmer, no psychosis. After 1 week, and when the level came back 0.9, patient was calmer, mild. He had a mild GI upset, and mood improved. Side effect is and management. So through this treatment and adjustment and week after week following the patient, he developed mild handshake tremors and increased thirst and urination. Instead of stopping the lithium, we manage these symptoms. So we decided to manage the side effect instead of stopping the medication. We encourage him to consistently improve his intake and improve the hydration. We adjust the dosage to a single night time dose once it is stable. So instead of twice, we adjusted the lithium dose to be one time. And we educate the patient to avoid unnecessary usage of beta blockers unless it's necessary. He tolerates the medication well and remains adherent. Something he struggled with historically. So he maintained taking his medication, even though he used to stop his medication and relapsing again. Then we talk about and decided the discharge plan and long-term planning. At the discharge time, Mr. J was happy, sleeping 7 to 8 hours per night, engaging in an outpatient planning. He was engaging, he was talkative, but it's not manic. He was cohesive. Thus, we schedule a lithium level check and CMP in a 1 month. So I educate him, come back in 1 month so we can check the lithium level and CMP, electrolytes and kidney function. And TSH every 6 months. So thyroid will be checked after 6 months, but the lithium level and the kidney function will be checked within 1 month. Also, I educate the patient and reminders about the lithium toxicity. Lithium toxicity signals that include nausea, confusion, worsening tremors, and muscle movement or ataxia. So before he left, he say something that stay with me. He say, Czech says, "This is the first time I feel normal, not dull or just steady." He said, "This is the first time I feel normal, not dull, but just steady." So that shows his mood is stable. It's not depressed or it's not manic, it's stable. As a provider, prescribing lithium requires patience. Prescribing lithium requires patience, trust between the provider and the patient, and vigilance. It demands laboratory monitoring and patient education, but it offers a durable mood stabilizer and life-saving potential. So lithium provides a durable mood stabilization and life-saving potential if the patient is patient, if there is a trust between the provider and the patient. Because when you talk to the patient, when you educate the patient, if they listen what you're telling them, if they believe the plan is working, if they take the medication the way you prescribe them, if they watch the symptoms, if they come back to the lab test, if they test the process, and you are vigilant for monitoring the labs, that is when it works the best. So this case reminds me that while new medication are often easier to prescribe, lithium remains the gold standard of bipolar I disorder manic episode, especially when used thoughtfully and collaboratively with respect for both. It is powerful and risky. When you consider lithium, how it is good for stabilizing the mood, and when you watch out the risks that it can have if it's not managed, it can work well. Lithium is especially effective in a classic bipolar I disorder. Baseline labs and ongoing monitor are the essential for lithium to be effective. Slow titration improves tolerance and adhesiveness. So when the patient improves, they will know this medication is working. As he say before, I never been felt normal this way. So when they know it's working for them, they will take the medication. they will see the difference. Side effects often can be managed rather than avoided. So you will tell the patient, we can manage the side effects. You don't have to stop the medication. Come back to the lab, we will adjust the dose. If they trust the process, as I mentioned before, they will listen and they will come back. This clinical case study is presented from the provider perspective, caring for a young adult patient with bipolar disorder and recurrent manic episode. The patient, as we talked about, is a 26 years old male with a multiple prior psychiatric hospitalization, each associated with medication non-adhesive. So he comes to the hospital, get new medication, stabilized, go out and stop taking the medication for some reason, instead of coming back to the provider or the hospital and getting new dosage or check his lab. He just stopped taking it. He presents with a classic manic symptoms include decreased sleep, pressure and rapid speech, grandiosity, impulsive decision making, and impaired judgment. That's what he came for. For a diagnostic standpoint, his illness follows a clear episodic course with period of a fully remission between the episodes. So he becomes better and then he goes out from the hospital and stop taking the medication. I'm cured, I don't have to take the medication. And then when he become worse or manic, his family notice he's not doing well and he realizes if he's with it. So previous medication that he tried include Depakote, which he discontinued due to unacceptable weight gain, Seroquel, which produced only partial symptom control, Lamictal, which was ineffective for acute manic. In considering long treatment, the provider primarily goal were sustained mood stabilization and relapse prevention and reduce of a suicidal risk. Because if the patient becomes out of the control and more manic, it can lead to suicidal ideation. Lithium was selected based on its durability, evidence-based demonstrated effectiveness on bipolar I disorder. It is superior in a preventable manic relapse management with many other alternatives. So it's better than other alternative and it's unique. It's associated with reduction of suicidal ideation and improves patient who had no significant medical conditions, normal base renal and thyroid function, and no contraindication to lithium therapy. A shared decision-making approach was used to emphasize a realistic expectations that needed a lab monitoring and the long-term nature of the treatment. So that is how the patient and provider come together and agree. This is what the patient needs. Lithium was not chosen as a last resort, but rather as a deliberate, evidence-based first-line maintenance strategy with the potential to improve durable mood stabilizer and meaningful functioning recovery. So that was the case study. Thank you for joining me today. I would love to see you in my next videos.